This presentation is a training tool that should be used to help and support the development of staff involved in screening diabetic feet. It should also be used as a refresher for those involved and can also be used by new members of staff, but it is not a substitute for attending the face-to-face competency training course organised by the Foot Protection Service. So, during the session today, what we're going to be covering is carrying out a diabetic foot screening, how to correctly identify patients who are low risk, moderate, high, and those that have active foot ulcers. We'll be reviewing patients' footwear, carrying out some basic advice that can be given to patients with regards to foot care, talking about record keeping and the importance of correct record keeping, and most importantly, when to refer and how to refer. So, when a patient attends for their annual screening or a screening appointment with yourselves, one of the first things that we actually do once we've got their shoes and socks off is we carry out a visual inspection of their feet. What's normal? What's healthy? A nice, healthy, pink, warm pair of feet. Does the patient have good pulses in their feet? Have they got any notable wounds on their feet? Does it look like they might have an infection? Have they got any changes to the shape of their feet, such as deformity? But why are feet with diabetes so different? There's been a lot of work carried out in the recent past around diabetic feet and looking at what we can do to improve the care that we deliver for our patients. Here's a list of some of the examples of the work that's been carried out over the recent years. Most recently was an update around the NICE guidance, the NG19, which was issued in January 2016. We've adopted the NICE Guidance 19 guidelines and turned them into our pathways for screening and referring patients with diabetes in Leeds. So like we've already mentioned, general observations that we make around people's feet when they first come in and they take their shoes and socks off. Skin colour, are their feet nice and warm? Do they have a nice equal temperature gradient as well between their 2 feet? For example, if somebody comes in and one foot is nice and warm, the other's stone cold, that's not necessarily normal. So what this is going to help cover what we would actually do in those instances. Looking for hair growth. Believe it or not, hairy feet, hairy toes, it is actually a sign of good circulation. The quality of the nails, the quality of the skin, changes to the shape of feet as well. So claw toes, hammer toes, bunions, operations that may have occurred in the patient's history as well. And looking at swelling and edema. So these are some of the things that you may come across in your clinics. Dry skin. The importance of noticing these things and identifying it as a potential risk factor, what can be done about them, who to refer on to, and how. So some of the major risk factors that we're looking at when screening patients with diabetes are loss of feeling. So when we're screening patients' feet, what we're looking at is the protective sensation, which is why we test with a monofilament. Poor circulation, peripheral arterial disease. Looking for gross deformity of patients' feet, again, bunions, claw toes, hammer toes. Does the patient have a previous history of ulceration? Does the patient have a previous history of amputation? And obviously, are there single risk factors present for this patient, or are there multifactorial patients? We also need to take into consideration the rest of the patient's history as well. So looking at other comorbidities that the patient may very well have, such as rheumatoid arthritis. Is the patient a smoker? Do they drink excessively? Patients with poor eyesight, self-management can be dangerous in some instances. Those patients who perhaps carry a little bit more weight around the middle, making getting down to their feet increasingly difficult. Patients who aren't particularly active as well. Obviously that increases the risk of them developing areas of pressure sores around heels. And then we're looking at other factors as well, so socio and economic factors as well. How long have they had diabetes for? Obviously, the longer that they've been confirmed with a diagnosis of diabetes, the more likelihood there is of patients developing problems with their feet. That's not always the case though. And again, talking about foot deformity, which can also lead to things like callus formation. Some of the most common triggers that we see to patients developing problems with their feet are inappropriate footwear, trauma, self-neglect, injury, patients going on holidays. We don't always think about that one, but it can be quite a detrimental factor to patients who don't feel very much, walking across a lovely tropical beach in the midday sun, burning the soles of their feet. Okay, so now what we're going to start talking about is the actual screening process itself, looking at what we're actually looking for, why we're looking for these things, and the importance of what each category means. So we're going to start off with a vascular screening. So in patients who have poor circulation or ischemic feet, their feet are generally cool to touch or cold to touch. They may very well have reduced or absent pulses. It might be quite difficult to actually find them when palpating them. The colour of the patient's feet as well. For example, somebody that attends and their feet are the same colour as my uniform, not going to be particularly good circulation to their feet. And again, using our other senses as well, we can actually see before we go anywhere near that foot that chances are we're not going to have much luck finding a good pulse. Pain. Pain can be a good indication that there is a problem with somebody's feet, whether it is abnormal pain, whether it is constant pain, what kind of pain it is as well. More commonly, patients with circulation problems tend to report problems when they are performing physical activity, so walking any distance, or when they tend to be in bed at night. But these pains tend to ease if they drop their leg out of bed or if they sit themselves on the edge. Pain isn't always an influencing factor though with patients with problems with their circulation. They may not be experiencing pain because of loss of sensation that could also be affecting their feet. Patients also tend to present with quite hairless, thin, atrophic, almost paper-like skin. Okay. So when carrying out a vascular assessment on somebody's feet, what we're asking now is that pulses are palpated. That's it. We don't ask if you can't find a pulse by hand. We are saying that there is no need to dig out a Doppler. The reason behind that is that although some people may very well have many years' experience in interpreting Doppler waveforms, not everybody does. And sometimes the waveform that you do end up with on a Doppler doesn't necessarily mean that they have got good circulation to their feet. Okay? So moving on and looking at neuropathy. What we're testing for when we're screening somebody for neuropathy is loss of protective sensation. We use a 10-gram monofilament. Okay, so a 10-gram monofilament is our protective sensation. In leads, we recommend that the 7 points are tested. So the apex of the first, third and fifth toes, the first, third and fifth metatarsal head, and the plantar of the calcaneus as well. When testing for neuropathy, we identify neuropathy as a loss of 1 point. So of those 7 points, if a patient scores 6, we would say that person needs to be referred on. Moving on and looking at deformity of patients' feet, what do we actually mean by that? So patients who present with high arched feet, bunions, claw toes, hammer toes, they alter the way that pressure is distributed throughout people's feet. Claw toes, hammer toes, they can rub on the inside of shoes and slippers. Bunions, they make people's feet quite broad and can sometimes, when patients attend, you'll notice that they can sometimes be quite red. Again, these areas that are prone to rubbing may very well end up with blisters, corns, calluses, and ultimately can end up with wounds developing over these areas if the pressure isn't addressed. History of surgery, as we've already said, history of trauma, previous ulceration sites. Okay. They're usually over areas of pressure, which is why foot ulcers you will tend to notice, particularly with patients who have changed to the shape of their feet, tend to occur over areas of pressures, whether it's tips of toes, tops of toes, bunions, heels. And something that's a little bit less common, but still very, very, very important to know about, and that's something called a Charcot. Okay, but we will cover that a little bit later on. So in this picture, we can actually see where the patient has developed some heavy callus over areas of pressure. So in this picture here at the bottom, we can see that this patient has actually developed a corn over the top of one of their little toe joints. And you can actually also see the discoloration in that area as well. So the discoloration in that area indicates that the area is under significant pressure to cause trauma to the skin underneath. So the healthy little blood vessels, the capillaries in the toes, have started to burst, and that's what's causing the discoloration of the callus. Okay. A Charcot foot will quite often present in your clinic as a patient with a red, hot, swollen, possibly painful foot. Something to bear in mind is that it will only occur in patients with neuropathy. Okay? Please, please, please bear in mind that diabetes is not the only cause of neuropathy. There are other reasons as well. For example, HIV, rheumatoid arthritis, specific medications, they can all lead to patients losing sensation in their feet. It more commonly affects the midfoot, the medial border of the midfoot, so over the arch of the feet. It can be triggered by trauma, but patients won't always recall that. For example, I've seen a patient who the only trauma that they could recall was that they stepped off a curb onto some uneven pavement. And that, we believe, was enough to actually trigger a Charcot from developing. As I've already said, it can present as a red, hot, swollen foot, but in the absence of an open wound. Okay, so a patient is presenting with a red, hot, swollen foot. Your first instinct may very well be to go to infection. And Charcot is quite commonly misdiagnosed and treated to begin with antibiotics because of the presentation. It can lead to an irreversible deformity of the foot. What happens within the foot is a microfracture or a small break in the bone causes inflammation to occur. Now, to you or I, where there's good sensation in our feet, we would probably be hobbling around on that foot. We may even have enough sense to get the pressure off of it. But these patients having neuropathy aren't necessarily going to be aware of the discomfort that it's causing. As a result of that, they continue to mobilise on it, causing further inflammation, further blood flow into the bone. And to give it a very, very, very basic overview, the inflammation, the increase in blood flow causes softening of the bones and a collapse of the midfoot, which can result in a rocker bottom shaped foot. So patients' feet can actually change shape, in causing further pressure to develop across the plantar of the midfoot. When we suspect a patient has a Charcot, one of the first things that we're looking for is a difference in temperature. Now, clinically, we would look for a difference of 2 degrees or more. However, if you're not able to, if you don't have access to a dermatemp or a skin thermometer in your clinic, I would just say use your hands. Does one feel significantly warmer than the other? Swelling. Obviously, we're talking about a lot of inflammation in this area. Pain. The importance of taking a good history on this patient as well. And actually, if you get the patient to sit on the side of a chair and put their feet on the floor, do they look the same? One foot looking significantly different than the other in combination with these other factors, may very well be an indication of Charcot. If you ever suspect that a patient has developed a Charcot arthropathy, we would always recommend contact the hot foot phone, and I've got their contact details as well for you to be able to take with you. Out of hours, send these patients to A&E, but I would always advise send these patients to A&E with a note saying, I suspect that this patient has a Charcot. Okay. Most importantly, advise the patient to rest. The more they walk around on that foot, the more trauma they're going to be causing to it and the greater chance of developing an irreversible deformity. So we have some photographs as well of a patient who developed a Charcot on the outer side of their foot, on the lateral border of their foot. You can actually see around this area just here where the pressure is building up over the deformity. So this patient is starting to get areas of callus building up there, which indicates that this is an area of high pressure. If this goes unaddressed, then that patient may very well ulcerate. Podiatrists quite often get accused of causing problems with people's feet as well. I'm sure that you've had somebody come in and say to you, I went to go and see the podiatrist and now I have a wound on my foot. Quite commonly though, what happens is that we will uncover a bigger problem. For example, a patient presenting with a corn on their toe with heavy extravasation, so that's the small blood vessels that have bled into the callus. After we've debrided that back, what we are actually presented with is a small ulceration to the dorsum of the toe. The reason that that's there again is because of pressure. The podiatrist hasn't caused that wound. We've debrided away the dead skin, uncovering the wound, which will actually allow it a chance to heal, providing we are able to address the initial problem of pressure. Again, this is another good example where somebody presents with callus on the bottom of their foot. It might very well feel a little bit soft or squishy, slightly spongy. You may even think that it looks slightly macerated. So the podiatrist has debrided that area away, and underneath we find that there is actually an ulceration. Again, our job is to work out what's causing these problems and address them. Patients that present with suspected wounds, or patients that present with open wounds, we would encourage you to refer straight away to the diabetic limb salvage service. Okay. When people go to see a podiatrist, they always expect us to go on and on and on about footwear, so I'd hate to disappoint. I'd like you to understand why we go on and on and on at our patients about the shoes that they attend clinic in. So as far as I'm concerned, what makes a good shoe is something that actually fits their feet, something that offers sufficient length, width, depth, something that's actually going to accommodate their toes. So those patients that do present with their claw toes or their bunions, it's not crammed in. We've all seen that patient that comes into clinic where the leather is distorted round a bunion joint, or you can see where it's stretched over the top to accommodate that toe that sticks up in the air. And yet they will try and tell you till they're blue in the face that these are the most comfortable pair of shoes that they've got. We'd always recommend an adjustable fastening as well. Lace up, Velcro, buckle. The reason behind that is that if patients do experience swelling, they can adjust it to be able to accommodate that swelling. An anchor around the ankle to support and hold the foot back there is going to allow for more space in the toe box. We would always prefer patients to wear everyday shoes with a heel less than 2 inches, 5 centimetres. Reason for that is the higher the heel, the more pressure there is on the forefoot, on those prominent joints. A smooth, seamless lining to a shoe as well. If you've ever put your hand inside a shoe and actually felt the stitching, decorative stitching makes shoes look really, really pretty, but where the material is all layered on top of each other, it increases the rigidity of it, meaning that it doesn't have very much give to it. And where you've got all of the stitching, again, Sometimes they tie off on the inside of the shoe, meaning that you can end up with a tiny, tiny, tiny little knot, which could rub on a toe, causing a problem. Always wearing socks or stockings or something inside their shoes as well. We do endorse trainers, hotter style shoes, those sorts of shoes as well. As a podiatrist, I spend my life wearing my trainers. Okay, they're comfortable, they support my feet, I can get my insoles in them, and at the end of the day, I'm not dying to get my shoes off. That is, to me, what constitutes a good pair of shoes. I quite often liken it to my patients of, if you have children, when you take them school shoe shopping, you are looking for the length, the width, the depth, the fastening. And as a result of that, if you relate it to something that the patients can actually relate it to themselves, they tend to understand in a little bit more detail what it is that you're actually looking for. So when we're talking about bad shoes, we're talking about the court shoes, the slip-on styles of shoes. Those ones where the patient can slide their foot into it, because as they slide their foot into it and they can slide their foot out of it, there's a small amount of movement in that shoe. That can cause friction, that can cause pressure, shearing on specific areas of prominence. You will also find that slip-on styles of shoes do tend to be a much tighter, much more snug fit across the front of the foot. The reason for that is that if they weren't, patients would just walk straight out of their shoes. Those hospital slippers, those lovely socks that they give you that have got the rubber sole to them as well, they're not perhaps the best pair of footwear to be giving somebody who can't feel what's going on underneath their feet, particularly when you've got all manner of people visiting this particular patient. For example, I could quite happily go and visit somebody at home and I might have a bit of grit on the bottom of my feet. That might come off on their carpet. As the patient's wandering around in just a pair of socks, that's not really going to provide them with any protection. For patients who have issues surrounding footwear, for example, they've tried several different styles and they can't find anything that fits, or patients that have gross deformity to their feet where we're just not going to find anything that's going to fit them on the high street, we can refer to the orthotist. They can actually create the patient a custom-made pair of shoes if necessary. They tend to have things like the reinforced toe box, generally an insole to help with distribution of pressure throughout the foot. Although this one looks like it's a lace-up shoe, actually it's decorative and it's a bit of Velcro, so it makes it easier for the patients to do up. Hospital shoes, orthopaedic shoes, are not what they used to be. Patients have a lot more choice, a lot more variety of colours than they used to. So far, I haven't encountered a patient here, touch wood, that doesn't like the shoes that they have been given. There has to sometimes be some tweaking because obviously these are custom made for the patient. Okay, so here's an example of a patient who has an appropriate pair of shoes but is also neuropathic. This is one of the reasons why, when talking to our patients, we would always recommend that they check their feet every day, that they check their shoes before they put them on. Can anybody hazard a guess as to what it is that's actually caused that? The patient's developed an ulcer on the top of their toe. Shoes too small? Close. There's a reason their shoe's too small. The shoe was sitting next to the nightstand, and as they've gone to bed, they've knocked their tub of vapor rub into their shoe, and then somehow managed to get their foot in as well. So their toe's been pressed up against that tub of Vic, and that's caused the pressure on the toe that has caused the toe to ulcerate. Another example of this is I've actually encountered a patient who was very apologetic because they were late for an appointment, couldn't find their little shoehorn to get their shoes on. When they came into clinic and they sat down and they took their shoes off, there it was in the bottom of their shoe, and they'd actually walked to the clinic with it in the bottom of their shoe. So again, the impact of the patient's circulation, sensation, foot deformity, and how these things can actually affect their feet. So getting them to inspect their feet regularly, inspect their shoes regularly, check the soles. This time of year, coming up towards Christmas, you'll be amazed how many of our patients are going to come into clinic and will turn their shoes over and find drawing pins in the bottom of them where they've been tacking up their Christmas decorations. Okay. When we are categorizing patients, the correct category and the correct information is important. So a patient who is low risk associated with their diabetic foot health will present with no risk factors. In other words, they have a perfectly healthy foot, palpable pulses, they feel all of the points that you're testing for neuropathy, no claw toes, no hammer toes, no bunions. They may or may not present with a little bit of callus. Callus alone is not a risk factor. That patient would be categorised as low risk. Now hopefully you have all had the opportunity to see some of the new information leaflets that have come around as well. The green, the yellow, the red and the blue. If you haven't, I have some examples that I can show you as well. A moderate risk patient. Now the thing about moderate risk is it's one single risk factor. Okay, it's all. So they present with a change to the shape of their foot, or neuropathy, or peripheral arterial disease, or non-critical limb ischemia. When we're looking at high-risk patients, anybody that has had a wound, so anybody that has had a previous ulceration to their foot, would be instantly categorised as high risk. Doesn't matter if their pulses are palpable, doesn't matter what their sensation is like. They may very well have previously been a low-risk patient that developed a wound on their foot. They will now be categorised as high because of having a history of ulceration. Scar tissue does not have the same strength of the tissue that was there previously, and as a result of that, this area becomes vulnerable to pressure and potential for re-ulceration. Anybody that has had a previous amputation as well. So somebody that has had a toe, midfoot, they can't have one foot that is high risk and the other foot low risk. It would always be the highest risk factor applied to both feet. Anybody that is on renal replacement therapy, so dialysis, okay? Dialysis is a high risk factor associated with diabetes. And then we're looking at the combinations as well. So any combination of our neuropathy, deformity, and non-critical limb ischemia, in combination perhaps with callus as well. As we've already said, we're also going to talk about the active foot problems as well. So if you suspect that a patient has an ulcer, a spreading infection, critical limb ischemia, so somebody who perhaps presents with pain, you're unable to find a pulse, their foot might be pale or it may be very cyanosed in appearance. In those instances, or if you suspect that a patient has a Charcot, a red, hot, swollen foot, with or without pain, we would always recommend a direct referral to the diabetic limb salvage service, followed up with a phone call. In the instance of these patients, we would want them seeing ASAP. So there is a referral form available on Leeds Health Pathways. I know that it's also available on System 1. Completing a referral form, emailing it off to them, and like I said, follow it up with a phone call so that they are aware there's an urgent referral for them. They may even be able to see the patient the same day. So looking at the referrals, the pathways, as I've already said, are on Leeds Health Pathways. We're under the diabetes section. So when you go into Leeds Health Pathways, if you click on the pathways themselves, there is one for diabetes, and currently the foot pathways are the acute and the non-acute pathways are the only two pathways that are currently there. That is due to be populated with more. Under each one of the pathways, you will find links to any information leaflet that you may require. We also have links on there if you require Urdu or Polish translation of the information leaflets that we have. We have an easy read version of all of our information leaflets as well, available on the pathways. They contain contact details, including email addresses and telephone numbers. So if you are ever in doubt, if you can't find it, Leeds Health Pathways. So low-risk patients wouldn't be referred to the foot protection service. Patients who present with no deformity, palpable pulses, no neuropathy, no significant callus to their feet. But if you still feel that these patients require some additional help and additional support with their feet, you can refer them to the core podiatry service, which is now based up at Stockdale House. If you complete a referral to the core podiatry service, all we would ask on that referral, please identify that the patient is low risk. If you are referring somebody who is moderate or high risk, please follow the pathway to the foot protection service. We're specialist podiatrists within the community of course, we are specialist podiatrists in the community that specialise in diabetes, diabetic foot management. So what we will do with those patients is, for the high-risk patients, which are the ones that I see, I will sit down with these patients for an hour, assessing, talking to, coaching about their foot health, providing any treatment that they might require, but also working towards a treatment plan. What's the patient's goals? Where do we want to get them to? How are we going to get them there? And putting in place a plan for what we're going to be doing for them in the future.